بتاعت البادي ايميجينج. واول توك هيبقى للدكتوره مي احمد مصطفى. العنوان When Cancer Tracks the Nerves Perineural Spread in Common Abdominal Malignancies.
Hello everybody, my name is Mai Ahmed. Today we will discuss perineural spread in most common abdominal malignancy. Our agenda will include definition of perineural spread associated malignancy with a special focus on pancreaticobiliary tumors, relevant image modalities, current status and future directions. Perineural spread is the radiological definition of tumor extension along the nerves, which equivalent to the histopathological term perineural invasion. Key pathway of the neural spread in abdomen is the celiac neural plexus, which is a central nervous system hub in the abdomen, which give major neural pathway. In our lecture, we will focus on three primary highways, which are plexus pancreaticus capitalis pathway 1 and plexus pancreaticus capitalis pathway 2, as well as gastroduodenal artery neural plexus. The celiac plexus is formed of two celiac ganglia on the right and left and superior mesenteric ganglia. The celiac ganglia can be visualized in 66% in patient, as we can see here on the yellow arrows. They are discoid or lobulated in shape of same density to the adjacent adrenal gland, measuring about 3 to 4 millimeters in short axis and about 2 centimeters in long axis. Apart from the celiac ganglia, the other neural plexus cannot be seen on image, so we use celiac and mesenteric arteries as landmarks for detection. Usually perineural spread manifests as increased attenuation or intensity or confluent soft tissue around the vascular landmarks. As regard the associated abdominal malignancy, we will focus on pancreatic adenocarcinoma, cholangiocarcinoma, and gallbladder carcinoma. First, we will talk about pancreatic adenocarcinoma. Usually, perineural spread with the pancreatic adenocarcinoma occur in two pathways, either posterior pathway, which include the plexus pancreaticus capitalis pathway 1 or 2, or the anterior pathway, which is the gastroduodenal artery plexus. The plexus pancreaticus capitalis pathway 1 is a part of the hepatic plexus originating from the right celiac ganglia and extending toward the pancreas behind the splenic vein and portal vein. As we can see on the axial CT image, there is a mass lesion within the head of the pancreas associated with soft tissue component just posterior to the portal vein, denoting perineural spread through the pathway 1. While pathway 2, originating from the superior mesenteric artery ganglia, extending along the superior mesenteric artery, as we can see on the diagram, along the posterior inferior pancreaticoduodenal artery, as well as the jejunal venous trunk to the unsnake process. As we can see on the axial CT images, there is unsnake process mass lesion with tongue-like extension encasing the posterior inferior pancreaticoduodenal artery, denoting perineural spread along the pathway 2. The anterior pathway is the nerve fibers along the gastroduodenal artery and extending along the common hepatic artery within the hepatoduodenal ligament toward the celiac ganglia, typically seen in pancreatic head and neck tumors. As we can see here on the oblique coronary format CT image, there is a mass lesion originating from head neck of the pancreas with soft tissue extension related to the common hepatic artery. Some facts about the perineural spread with pancreatic adenocarcinoma. Most frequent pathway is the plexus pancreaticus capitalis pathway 2, followed by pathway 1. The tumor location allow prediction of the route of invasion. Characteristically, tumors within the head of the pancreas is spread through pathway 1, and tumors within the unsnake process spread along the pathway 2. Unlike the lymph node, perineural spread is not correlated with tumor size and can occur in even in small tumors less than 2 centimeters. The second tumor is cholangiocarcinoma. Cholangiocarcinoma can be either intrahepatic or extrahepatic. The intrahepatic can be divided into right or left lobe tumors, and the extrahepatic can be divided into upper 2/3 or lower 1/3 of the bile duct. The right hepatic lobe tumors show perineural spread along the nerve fibers around the common hepatic artery within the hepatoduodenal ligament. As we can see here on the CT images, there is a right lobe mass lesion with soft tissue density around the common hepatic artery extending to the right celiac ganglia. While the left hepatic lobe tumors show perineural spread along the left gastric artery within the gastrohepatic ligament. As we can see here on axial CT images, there is a left lobe mass lesion associated with soft tissue confluent mass around the left gastric artery, denoting perineural spread. As we said, that extrahepatic cholangiocarcinoma can be divided into the upper 2/3 bile duct tumor, which may show perineural spread along the hepatic plexus tributary around the common hepatic artery, as we can see on the axial CT image. While the lower bile duct, lower 1/3 bile duct tumor can either spread along, extend cranially along the common the hepatic neural plexus. As we can see on coronal first coronal CT image, there is a mass lesion within the lower bile duct associated with soft tissue density encasing the common hepatic artery, superior yellow arrow in the second image, or extend medially toward the unsnate process encasing the superior mesenteric artery and inferior pancreaticoduodenal artery, which is plexus pancreaticus capitalis pathway 2. Last tumor is the gallbladder carcinoma. Few studies describe the radiological findings of the perineural spread, yet one of them suggests infiltrative stranding or soft tissue plaque can occur along the common hepatic artery, celiac artery, or superior mesenteric artery. As we can see on the second axial image, there is a soft tissue component along the celiac trunk and common hepatic artery. The third coronal image shows soft tissue mass encasing the celiac trunk and superior mesenteric artery. Associated and relative image modalities, CT is considered the cornerstone image for detection and prediction of the perineural spread, owing to its high spatial resolution, and it is less susceptible to motion artifact when it compared with MRI. Typical morphological features of perineural spread similar to MRI, including increased attenuation or signal intensity or confluent perivascular soft tissue along the vascular landmarks. Advised CT technique is thin cut CT in axial, arterial and venous phases with oblique multiplanary format, sharply delineate the vascular landmarks. Also in MRI, advised high field 3 Tesla scanner with thin slice post-contrast T1 fat sat images. BET is a problem-solving image modality for differentiation post-treatment changes versus true persistent or recurrent tumoral tissue. Why does it matter? It impacts the prognosis as it increases the rate of recurrence and decrease overall survival rate. Also, it affects the surgical approach, neoadjuvant chemotherapy, and pain management strategies. As we can see on axial CT images, there is locally advanced pancreatic mass lesion, and patient underwent celiac ganglia neurolysis. Currently, perineural spread is not part of the TNM staging, and its role in resectability not well defined, yet given its potential impact on patient outcome, it's anticipate that perineural spread will be integrated in future guidelines. Thanks to new techniques using radiomics and machine learning, these methods can extract quantitative data for accurate and non-invasive method of diagnosis preoperatively. Take-home message: perineural spread is under-recognized route to tumor dissemination in abdominal malignancy. It's best identified on contrast-enhanced CT. It's not size-dependent. Recognizing the anatomical plexus and their vascular markers are crucial for accurate diagnosis. Perineural spread not yet in staging system, but significantly affect prognosis and clinical management. Thank you.
Thank you, Dr. Mai, for this well-illustrated presentation for an important issue. Any questions or comments?